Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullah. We are discussing acute abdomen part 3. 40 years old male patient presented with periumbilical or epigastric pain migrating to the right lower quadrant of the abdomen. He was lying down with the flexed hips and knees to reduce movements as to avoid worsening his pain. Later on, he presented with nausea, vomiting and anorexia. Provisional diagnosis after physical examination was acute appendicitis. What are the imaging modalities used for the assessment of appendicitis? We have CT scan and ultrasound. This is our routine modality and this is modality of choice. Here we see ultrasonography of the inflamed appendix. We can see diffuse wall thickening which is more than 3 mm, and this is distended or dilated lumen. A typical picture for appendicitis. This is axial view of the appendix. We can see grossly thickened wall and we can see lumen is distended or dilated. Very tiny strip of fluid is appreciated in periappendicular region. So this is an example of appendicitis with the help of ultrasound. Here we have CT examination. We can see this is normal abdominal CT. With respect to appendix, we can see very smooth and thin walled appendix. Tiny air pocket is noted within it and surrounding fat planes are preserved with the normal fat. Contrast is noted in the cecum and in adjacent small bowel. Small paraumbilical mental hernia is noted. Here we see this is an example of appendicitis. We can see dilated small gut, mild diffuse wall thickening, lumen is bit distended and there is significant inflammatory changes in its surrounding. So this is an example of appendicitis. Another example where we can see there is stone or appendicolith in its topmost portion, and we see that wall is bit thickened, lumen is distended, there is mild enhancement of the wall as well, and hazy surrounding fat planes are noted, suggesting inflammatory changes in its surrounding. Now we have seen two modalities, that is CT examination and number 2 ultrasound examination. So ultrasound is our routine modality and CT is modality of the choice. It becomes difficult sometimes to assess appendicitis in thick patients, and ultrasound is good for the assessment of appendix in lean and thin patients. So whenever we feel difficulty in assessing appendix with the help of ultrasound, either because of thick body habitus or because of retrocecal position, we prefer CT examination, which is the best modality for its assessment. Case number 2, we see 50 years old male presented with the history of abdominal pain in the left lower quadrant. Now we are concentrating on left lower quadrant with the nausea, vomiting, constipation, flatulence and bloating. The patient presented with the fever and WBCs were raised. After physical examination, provisional diagnosis was made, which was a diverticulitis. Here we see there are multiple modalities for the assessment of diverticulitis. Number 1 CT scan, number 2 barium enema, and number 3 colonoscopy. This is an example of colonoscopy where we can see multiple diverticula. Here we have an example of barium enema. We can see multiple diverticula in sigmoid colon and descending colon. Barium enema and colonoscopy is contraindicated in active diverticulitis. CT will be the modality of choice in this situation. Here we see this is sigmoid colon small thick walled diverticula is noted. There is nodularity and stranding in its surrounding, suggesting diverticulitis. So CT is the best modality, having 94% sensitivity. We can not only localize diverticula, we can also assess its complication. Wall of the diverticula should not be more than 3 mm, and if we see nodularity and stranding in its surrounding with thick wall diverticula, it means that it is inflamed. Another example where we can see this is cecum and adjacent portion of the ascending colon. We see multiple diverticula and there is inflammatory changes in their surrounding, suggesting diverticulitis. Another example where we can see multiple diverticula are noted in the sigmoid colon. In here we see diffuse wall thickness and there are multiple tiny air pockets and collections, suggesting associated surrounding abscess formation. So this is a complicated case, and CT is best modality for the assessment of perforated diverticula or diverticular abscess. This is another case. 71 years old gentleman visited with the GP complaining of the blood in his urine. He has had a number of UTIs in the recent years. We see X-ray of the KUB. This is lumbar spine, sacroiliac joints, iliac bone, hip joints, and we see a couple of bladder calculi. We can see bladder calculi can come from kidneys, number 1, number 2 because of repeated UTIs, because of neurogenic bladder, because of obstruction, that is outlet obstruction from the bladder. There will be stasis, which can also lead to the passive stone formation in the bladder. Similarly, bladder diverticula can show stones. Imaging modalities for the assessment of the renal calculi, ureteric and bladder stones: X-ray KUB, IVP or Ivu examination, ultrasound KUB and CT KUB. In routine we use X-ray KUB and ultrasound KUB, but CT KUB is best modality for the assessment of ureteric calculi. And let's see their examples. Here we see lumbar vertebrae, lower dorsal vertebrae, SI joints, hip bones, hip joints. We can see multiple tiny symmetrical pedicles on both sides of the vertebrae, and here we have spinous processes. Lower ribs are noted symmetrically on either side. Lumbar vertebrae shows normal height with intact end plates, and intervening disc spaces shows normal height as well. So this is a normal picture of the lumbosacral region. Multiple ribs can be seen, and this is a psoas shadow. We can see a renal outline over here, this one on right side and on left side. We can trace ureters along tip of the transverse processes, then at the level of the spine. Here we do not see any abnormal calcific density in renal, ureteric and bladder area. Here we have multiple calculi of variable sizes. Few of them are Staghorn stones. We can see stones with the help of ultrasound as well. Here we have ultrasound examination. We can see stone in the upper pole of right kidney, and this is liver. Here we can see right kidney, and this is central echo complex, which is because of combination of the renal pelvis, renal vessels and fat. So it shows increased echogenicity as compared to surrounding renal parenchyma, which is relatively hypoechoic. And here we see there is stasis or back pressure leading to obstruction and mild to moderate degree of hydronephrosis in the right kidney. We can also see thickness of the surrounding renal parenchyma, and we need to measure in upper, mid and lower pole for the assessment of renal parenchymal thickness in those cases who presents with mild, moderate or severe hydronephrosis. Here we have Ivu examination. After giving contrast, we take multiple KUB images, and this is a nephrogram on right side left nephrogram contrast is excreted into renal pelvis. Both ureters can be outlined, and this is urinary bladder. There is impression on the dome of the urinary bladder because of uterus. So this is a normal cupping pattern of the calyces, normal renal pelvis and normal ureters. We have another example where we can see Ivu showing dilated pelvic glycel system and dilated ureter. There is filling defect in right lower ureter just above vesico-ureteric junction because of stone, leading to mild hydronephrosis and hydroureter. Another example we can see, normal nephrogram is noted on right side, and this is pelvic glycel system. Contrast outlines PCS and right ureter showing normal caliber. Here on the left side we are unable to see pelvic glycel system and left ureter, but there is dense nephrogram on this side. Delayed images shows mild hydronephrosis and hydroureter, and there is stone in left vesico-ureteric junction. So we can assess level of obstruction, number 1, and number 2, degree of obstruction as well. That is mild, moderate or severe hydronephrosis. This tells us the degree of obstruction, and we can also see the level of obstruction as well. Here we have an example of CT of abdomen, that is KUB area. We can see stone in mid pole of the left kidney. Right kidney is unremarkable. Psoas and iliacus muscles, and these are the gluteal muscles on both sides, iliac bone and lumbar vertebrae. Here this is axial image, and this one is the coronal reconstruction. We can see stone in the mid pole, and there is pelvic glycel system on left side, right kidney and right pelvic glycel system, aorta, left renal vein, IVC, superior mesenteric artery and the vein. Another example we can see right kidney, right pelvic glycel system, and we can see left ureter which is bit dilated. Here we can see left ureter which is bit dilated. These are psoas muscles. Here in the pelvis we can see there is tiny calculus causing partial obstruction, and this is located near left vesico-ureteric junction. This is urinary bladder, and we see seminal vesicles, and this is lower rectum. So left ureteric calculus causing mild dilatation of left ureter and left pelvic glycel system. So this is a stone leading to partial obstruction of the left renal system. Let's see, this is coronal reformatting. We can see left kidney, and this is pelvic glycel system, left upper ureter, and tiny calculus is noted leading to partial obstruction, mild hydronephrosis and hydroureter. Another case we can see left kidney, mild dilatation of the left upper ureter, and there is partially obstructing calculus in it. Another example we can see, this is left kidney, right kidney, left renal pelvis which is mildly dilated, left ureter is dilated as well, and there is tiny calculus leading to mild degree of hydronephrosis and hydroureter. And we can also see the exact level of the stone. We can also measure its density. We can also take its size, and we can also comment on degree of obstruction, that is mild, moderate or severe. Now we can see that there is tiny calculus in lower third of the right ureter. So we conclude that CT is the best modality for the assessment of ureteric calculi. We can take the density, we can measure its size, and we can also comment on degree of obstruction. Thank you very much. Assalamu alaikum wa rahmatullah.